Hello, my name is John Weinstein, and I'm very excited to speak to you about my work in collaboration with the Global AIDS Interfaith Alliance, or GAIA. GAIA Malawi operates mobile health clinics, or MHCs, in Mulanje district in order to expand access to primary health services for Malawians living in remote areas far from health centers. Malaria is one of the most common conditions screened for and treated at the mobile health clinics, accounting for 20 to 40% of monthly clinic visits. Over the past several years, as can be seen in this chart, routinely collected programmatic data from the mobile health clinics has shown a decrease in the proportion of malaria cases in children under 5 compared with those individuals older than 5, with a particular increase in cases among children from 5 to 13. This phenomenon has been previously noted with school-age children being identified as a key reservoir of malaria infection within Malawi. They have a higher prevalence of both symptomatic and asymptomatic malaria infection and lower bed net usage compared to other age groups. Additionally, they are treated less often and more often brought to informal malaria treatment providers. Thus, to better support the local health authorities' goal to reduce malaria infection and associated morbidity, this study aimed to identify environmental and behavioral determinants fueling malaria transmission among school-age children in Mulanje district. We performed an age-matched case control study between November and December 2019 among mobile health clinic users in Mulanje district in Malawi. Participants were identified through mobile health clinics operating in 3 traditional authorities. Cases aged 5 to 13 were enrolled in the study if they had malaria symptoms and received a positive malaria rapid antigen test. Controls visited the same clinic as the case and were confirmed to have a negative rapid antigen test for malaria. Data was collected using a household questionnaire which collected information on demographics, self-reported behavior risk factors, and observed environmental risk factors. As previously identified, school-aged children were more likely to have experienced malaria in the past 3 months compared to other family members, especially those under 5. This was associated with lower reported bed net usage and more reported activity outside after dark compared to other age groups. And within this age group, bed net usage decreases and being out after dark increases with age. Cases were particularly at risk for malaria, however. Cases had experienced malaria more frequently in the past 3 months. Nearly half of cases experienced malaria 2 or more times over that time compared to only 21% of controls. This was one of the strongest predictors of case control status. Thus, we explored the behavioral and environmental risk factors associated with this increased risk. Cases and controls reported similar rates of daily bed net usage, playing outside after dark, wearing long sleeves or pants, and indoor residual spraying. Those behaviors most commonly associated with increased or decreased risk for malaria. Cases, however, were far more likely to be female. 43% of cases were female compared to 55% of controls for an odds ratio of 0.62. Cases were also far more likely to cook indoors. 47% of case households cooked indoors compared to 29% of controls for an odds ratio of 2.15. All study participants lived in environments conducive to the spread of malaria. Nearly half had debris surrounding the house in which water could collect during rains, and in fact, 3/4 of participants had stagnant water within 20 meters of their house at the study visit. Nearly all lived near bushes where water could stagnate or near a maize plantation. These environmental risks were all similar between cases and controls. However, controls were far more likely to live in houses of high quality, 17% of control versus 6% of cases, whereas cases were far more likely to live in houses made of low quality, 32% of cases versus 21% of controls. Housing quality was a composite variable based on the materials used for flooring, walls, and roof. There seemed to be a great deal of clustering of malaria within households. The family members of cases had experienced malaria more frequently in the past 3 months. 36% of cases had 2 or more family members with malaria within the past 3 months compared to only 18% of controls, an odds ratio of 2.43. This image shows the location of villages for participants within the study in relation to waterways. Color indicates the proportion of cases within the village. Size indicates the total number of participants within the village. You'll notice that there are 2 regions suggestive of malaria risk clustered around temporary waterways around Mulanje district. Right here and right here. Thus, our study has found that all school-aged children are at an increased risk of malaria compared to those under 5, which is associated with reductions in bed net usage. Global targets such as the Millennium and Sustainable Development Goals direct resources towards children under 5, and thus they are well protected against illness. However, there is a lack of attention towards school-age children, which is out of proportion to the burden of malaria. Differences in housing quality, gender, and indoor cooking appear to further predispose one for malaria, and these minor differences are amplified within the household and village to further increase risk. Even though cases have experienced malaria more frequently and they are more aware of how to prevent malaria, due to seeded cases, they are unable to prevent reinfection. Thus, it suggests individual and community level interventions are needed to reduce the malaria burden in the region. Given the increased risk among male children, they should be targeted for education and behavior change. Additional research on the gender-specific malaria risk among school-age children is also warranted. Additionally, indoor residual spraying and household improvements can prevent malaria transmission to the index case, as well as the transmission of Plasmodium gametocytes to a mosquito. Targeting indoor residual spreading to high-risk areas, which has been found to be effective at reducing malaria burden, could be used to prevent insecticide resistance and minimize financial constraints. The latter may also reduce the rate of intra-household transmission. To further minimize transmission within households, treating whole families rather than just the positive cases through preventative prophylaxis may be effective. Prophylactic malaria treatment has already been shown to decrease the prevalence of P. falciparum and the risk of clinical malaria infection among school-aged children. Adults and adolescents in Malawi have a high level of asymptomatic malaria, which would otherwise go untreated and increase risk of transmission within the household. Thus, while there are additional costs associated with providing malaria treatment to those without transmission, this may be a cost-effective strategy due to prevention of future infections and long-term healthcare costs. Environmental changes at the community level, like removing standing water and moving bushes away from households, can prevent malaria transmission within the family and village. Interventions such as these have already been found to be effective at reducing the risk of malaria. And with that, I would like to conclude by thanking my collaborators, the Malawi team from Gaia for conceptualizing the study and collecting the data, and Chelsea Nash for preliminary work on malaria knowledge that informed our study, as well as the study participants and the people of Mulanje for their time. Thank you.